Okay, let's get started with this week's Miami Global Brain Tumor Symposium. Thank you all so much for joining us for our last three sessions of the year, starting with this week's. Just a little bit short intro before we get started with tonight's speakers. My name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons here at the University of Miami, and I lead our research efforts for brain tumors. I'm joined tonight by Dr. Morcos, who's professor and co-chairman of our neurosurgery department. He's also the director of the cerebrovascular and skull-based program. Dr. Komatar is a professor and program director of our residency program, also director of surgical neuro-oncology. And Dr. Benjamin, assistant professor, skull-based and brain tumor surgeon, who's also director of our skull-based laboratory called the Keynes Laboratory here at UM. Each week we put this on. This is our 30th session ever since COVID started. COVID is still going on, and so are we. But I couldn't do this without the great help of all the administrators and support from the University of Miami, the Sylvester Comprehensive Cancer Center, and the Neurosurgery Department. So thank you to all of you. Anybody has more questions about these seminars or about our neurosurgery department here in Miami, you could always find us on our website. We're also active on social media, on Twitter, YouTube, and on Instagram. All of these symposiums are recorded, and you could see them on our YouTube departmental website. Quick shout out, we have multiple symposiums going on now, one for pediatrics, but tomorrow's is Dr. Morcos' cerebrovascular and skull-based symposium. We'll be doing a panel evaluation of complications in neuroendovascular procedures for the treatment of aneurysms. So be sure to check out that one tomorrow, same time at 5 o'clock. It's always interesting to hear everybody's trials and tribulations and complex vascular disorders. Also next week, next Wednesday on our Global Brain Tumor Symposium, a quick sneak peek will be Dr. Vogelbaum joining us from Moffitt to talk about clinical trials and for neurosurgery. Some housekeeping. Please, we try to make these symposiums as interactive as possible, so use the Q&A button at the bottom, and we'll try to get to all of your questions in between tonight's speakers. We don't offer CME, but you will get an email confirmation documenting your participation. And please be sure to like, follow, and share our videos on Instagram, Twitter, and YouTube so we continue to grow and share all the knowledge of our excellent speakers tonight with more interested in neurosurgery. So tonight we have outstanding panelists joining us from around the country, starting with Dr. Molinatero Gunel, who's joining us from Yale. She is the Associate Professor of Neurosurgery and their Clinical Program Leader in the Brain Tumor Center at Yale. She's also the Chief of Neurosurgical Oncology and Primary Brain Tumors. And she's done some outstanding work in meningiomas, and I'm sure we're going to hear about that later on tonight. Dr. McGill, who's one of my junior residents, who's now a fellow at Ohio State, doing an endoscopic skull-based fellowship with Dr. Preladello. He just signed on to Northwestern, so congrats, Stephen, as one of their future skull-based surgeons, and he'll be talking some about his work with Dr. Raleigh at UCSF on meningiomas. Dr. Benjamin, who I already introduced, but she'll be also giving her aspects on radiosurgery and also complex meningiomas, and Ashish Shah, who's one of our chief residents, who is doing an R25 fellowship and joining the NIH next year for his fellowship. Our keynote speaker, very, very excited this week to invite one of my good friends and mentors, Dr. Dunn, who joins us this week to talk about meningiomas. He's a current professor and Harry Wilkins Chair of the Department of Neurosurgery at the University of Oklahoma, where he joined in that position in 2018. He's a world-renowned and very well-established brain tumor and skull-based surgeon who's done outstanding work in not only meningiomas, but many other skull-based and brain tumors. He did his training at Harvard, both his MD, internship, and residency, where he finished at Brigham Williams Hospital, training very closely with Dr. Ed Laws to learn pituitary and skull-based surgery. He then went to the University of Arkansas, where he studied under Dr. Al-Mefti and continued his skull-based training, and then they both ended up going back to Harvard for many years. He was there for 8 years, built a very, very comprehensive and busy skull-based practice, established a fantastic laboratory, and did much of his work publishing over 300 papers on meningiomas and all other kinds of brain tumors. Many of these papers are in extremely highly impact factor journals like Cell and Nature, and has really just done tremendous work for the field. He transitioned his work to Oklahoma, where he's continued to be very, very well funded. And where he continues also his laboratory focused on functional genomic techniques in human cancer cells and brain tumors. He's also a president of the Oklahoma Neurosurgery Society. He's on the board of directors for the Society of Neuro-Oncology. He's also the 2021 Tumor Section Satellite Symposium co-chair. And in my search, I also found he's one of the only neurosurgeons who has a website on celebrity pop info. And he also is skydiving here with his patients. And I'm not sure if I'll include that story today, but it's a great news article talking about support from your neurosurgeon to patients. The fact that he went skydiving is just truly an amazing feat. So Dr. Dunn, thank you so much for taking out the time to talk with us tonight. I know you have a lot to share, and hopefully you could fit into 40 minutes.
Well, Dr. Ivan, thanks very much for that introduction, and I'm going to share my screen. So back up first here, just to remind everybody, and first of all, it's great to be with the Miami group, Dr. Komatar, Morkos, Ivan, Dr. Benjamin, and I'll get to the highlight of being with these panelists. Also, all of them are really established in this field. But just a little reminder, I know all you beautiful people are there in Miami, but there's even more beautiful people here in Oklahoma. So just we are at the center of where it's all happening here. And if you watch a talk from Miami or Bill Colwell, you know, he's got his center in the heart of the mountains, and it's really beautiful. So no mountains, but we have a really beautiful center and a brand new hospital, and just excited to share that with you. But I was asked to talk today on precision in meningioma, and we often think precision means precision medicine, and I think we'll talk a little bit about that, and I'm sure as will the panelists, but precision also means an enhanced understanding, and I also really want to make sure that we don't forget still the single most important precision medicine weapon we have in meningioma, which is surgery, which just my own opinion sometimes gets a little bit of backseat as other elements of meningioma care research advance. Just Google precision medicine and you see hundreds of pages of incredible diagrams. Even Harvard Business School is getting on the act down here. But let's go back to where precision medicine or precision in meningioma really began formally. And not to reference the Brigham because I trained there, but that really is where this began with Louise Eisenhart and Cushing. And this was really the first formal canonization and annotation of this tumor formally as an entity. And if you haven't read, if you're really a meningioma aficionado and you really want to go back and read Harvey Cushing's and Eisenhart's original text, it's incredible, very prescient, very relevant today. The only thing that's missing is an MRI and a CT scan, but very relevant still today. But I show this just to show you that they had a classification scheme really from the outset in a bid to classify meningioma. So you had in the 1930s, you had this initial foray into this new tumor that was canonized. No microscope, but over the next 10, 15, 20 years, you had this developing experience with these intrepid surgeons around the globe. And we're very US centric, obviously, in neurosurgery, but a lot of this work was happening outside the United States. And this is a great example of these accumulating experiences in operating on meningioma. The only thing we could do with meningioma in the mid 20th century. And Oliver Corona was really at the forefront, at the vanguard of that movement, learning how accumulating large experiences with meningioma. If you wanted a meningioma operation in the 1960s in the US and you wanted your surgeon to use a microscope, I had a few patients in Boston that had this conundrum in the 60s themselves. You either had to go to the East Coast with Leonard Mallis of the bipolar or the West Coast with Rand and Kersey. It's sort of interesting to think that those are the choices you had in the 1960s as the world was beginning to experiment not only with a microscope, but to develop an increasing experience with meningioma surgery. You know, right around this time, not that all of these are connected, but you had a pediatric neurosurgeon take a few years off and go from Australia and go to Oxford and would annotate Cairns and Pennybaker's experiences with meningioma and would introduce the world to this single author paper, which is under quite a bit of scrutiny right now, but still is very relevant. The idea being obviously that the less aggressive the resection, the increased risk of recurrence, and there's survival relevance there. So you had the formalization of meningioma as an entity, increasing experience with surgery. At the same time, this idea that more aggressive surgery matters, and that many authors have since validated that holds true across different grades of meningioma. And then you had the introduction of the microscope. And if you put all those things together, you then enter this, and it'd be interesting to hear Jacques' perspective on this 20 to 25 year period of the single surgeon defining an approach and introducing the world to a specific meningioma and a specific fossa in the skull base in particular. And I apologize, these are all male surgeons. That just was the phenotype and the epidemiology at the time. But I think these are representative of this intrepid surgeon path at the time. And if you think about what constituted this evolution in surgery, really it was this developing series of skull-based approaches that all of us use, although those are also under attack. And it was a notion that microsurgery matters for meningioma, and also the idea that you have to be able to handle veins, and in particular the sagittal sinus and the transverse and sigmoid sinus with meningioma surgery. But this constituted the literature in that period, was this experimentation with adding increased exposure to standard craniotomies, adding the orbit, adding the temporal fossa to the frontal craniotomy, adding and then putting it all together to a COZ. And now you can do an eyebrow, or many of us experiment, or many of us have these at our disposal and implement them weekly, using especially the anterior fossa extensions, medially temporal fossa, using the orbit. And these are just customary accepted techniques at this point. But I want to go through a few around the clock, if you will, of just standard meningiomas, and just again support the notion that despite our advances in other elements of meningioma biology in particular, that I know we'll get to, that surgery still remains the very best weapon that we have to help our patients with meningioma. And this actually, this type of case has been shared on other Miami symposia, but very standard case you'll see in practice. And for me personally, this is a cranial operation, and part of the reason why is that you can't see what you can't see. So there's stippling of tumor lateral to the optic nerve, and a small little supraorbital craniotomy. You're looking right down at this, for trainees, the right optic nerve here, and you can decompress the optic canal, remove the tumor, and you can remove the clinoid and remove all of the this stippling or icing of disease. As many of you I know agree, meningioma is really a disease of the dura, not just a solid block emanating off a focal area of dura. So you have to have an exposure that really allows you to see more than what an MRI suggests. And just to touch on this, and I think Dr. McGill is in Ohio State right now, and might have some comments on this, but there are some limitations cranially. This is Professor Ohata from Japan. There's a great slide showing you can't see what you can't see if you're doing this endonasally. You can't see that icing of disease laterally. And many would suggest that from the top, supraorbitally, that right underneath that optic nerve, if laterally, can be a blind spot, but you can overcome that with other surgical adjuncts. I think even the orbit, some extended skull-based approaches are also coming in and out of vogue. And I would just suggest and show very quickly what removing the orbit, simple technique affords you in this left-sided supraorbital approach. The minute you open the dura, you are right down at the optic nerve, and you can see lateral to the optic nerve all this diseased dura that's not necessarily very obvious on an MRI. So for me, I like cranial approaches for these these tumors. Again, I think even the COZ, there's emerging literature about why do you need and daily with our trainees and with other faculty, why do you need the orbit and the zygomatic arch removed. But especially again for trainees, this is not a meningioma, but removing the orbit, removing the zygomatic arch often allows you to look get a much more superior trajectory and have that temporal lobe swing out if you want full access for a tumor. Again, this is craniopharyngioma, but for meningiomas that may have increased extent along the skull base and that's not suggested by your MRI. So with a COZ here, there's no retraction really to speak of, and you have access to lamina terminalis, posterior fossa. I'll show in a second. Here's the lamina terminalis here, and a beautiful view back to the basilar artery here in a second. And you can do a posterior clinoidectomy with very carefully with a sonopet as well. So I think for meningioma surgery as well, I personally, not just because I train with LMFD, but I think there's still a very much a role for larger skull base approaches. But again, you had other surgeons attaching themselves to other approaches. So we still refer to Dolink every week in perfecting the extradural approach to the pituitary fossa, anterior fossa, middle fossa. And I think if you're dealing with meningioma as a surgeon today, again, another point of controversy, I still think the cavernous sinus should be in your wheelhouse, and these approaches, especially Dolink's approach, should be one with which you're very familiar. In my personal practice, I do think consistency matters, and that's certainly where I've landed is the cavernous sinus and navigable space. I think the answer is yes. But is that an appropriate area to remove meningioma? I think it's hard when the tumor is very firm. When it's soft, it's a very very navigable space. This is not a meningioma, but a recent case here, right side, and this is V3 GSPN, and the same sort of lateral cavernous sinus approach you could use to access an intracavernous meningioma if the consistency was right and if the indications were right. This video is not going to play, but again, you had another in the 70s, 80s, early 90s, single surgeon attached with these approaches. So this was the notion you could reach the posterior fossa through the middle fossa, and that approach really, the middle meningeal is unlocks that space to allow you to access the petrous apex. And I just realized this video is not going to show, but here's a young woman with an enlarging mass. Radiation is certainly an option, but I personally, the younger the patient, the less likely I am to use radiation, and a perfect case for accessing the posterior fossa component through a middle fossa approach. You had Bernard Georges and others teach the world how to access the ventral aspect of the brainstem. Through, just as we would drill a sphenoid wing to have access to the carotid cistern and increase our visualization. When you remove part of the condyle or do a partial condylectomy, you have dramatically increased exposure to the ventral aspect of the brainstem, where many meningiomas are dealt with. Personally, I take this down layer by layer. This is a standard Oklahoma patient is generally a little bit larger habitus. You can see the soft tissue in the back here. Here's a large foramen magnum meningioma. And I just want to illustrate a few points. If you implement these and employ these skull-base approaches, you're able to roll that dura, open that dura more ventrally. And for me personally, that'll come here in a second. If I'm not seeing the 11th nerve right when you're opening the dura, or in front of the 11th nerve rather, you haven't taken off. And here's the condyle. And the more laterally you take that, the more you can roll that dura, and you can have you should be able to see that ventral dura really after you open the dura here. And she had no motor evoked potentials before surgery. And so you really can't touch the cervical medullary junction in this operation. You have to create that space here and not behind you. And her, as the case progressed, she had full restoration of motor evoked potentials if you do not retract behind you. The last couple of operative approaches, and then you had, I love this paper by Hakuba. If you haven't read his work, you really should. But he was summarizing the experience with clival meningioma in 1977, and essentially almost a 70% mortality rate at the time. But Hakuba introduced to the world, and LMFD would capitalize and refine that later. the notion of combined posterior fossa middle proximal approaches and would to Petroclival and clival region. And again, this is really where LMFD's made his name, but the notion of reaching the petroclival meningioma, not through a retrosigmoid, but through the temporal bone and the tentorium. And the way we typically do it is posterior fossa and temporal craniotomy in one flap, partial mastoidectomy, and then you can section the tentorium if the venous anatomy is right. And I'm just going to show, as a segue into the next portion of this talk, just an example of that here. Younger woman, again, we could debate how to manage this, how to treat it, radiation, surgery, what surgical approach, but this is the left side, and a really, really perfect case for a Petrosal approach. And you've got the sigmoid sinus here, middle fossa here, and I'm going to fast forward through a little bit of this. The working distance that this affords, you're really right on the tumor, as you can see here. Just in the interest of time, I'm gonna fast forward here, but notice nice resection. She did fine, but there's residual around the carotid, and that's a lifelong concern for that patient, whether or not you radiate it or observe it. And I would still contend today that surgery is the foundation of precision medicine for meningioma, although precision medicine typically is associated with other connotations today. I want to show this case to introduce the notion of the difficult meningioma. This is a spouse of a neurosurgeon, and it was referred as a sphenoid meningioma, but if you watch closely, it's infratemporal fossa, orbit, sphenoid, cavernous sinus, so anything but a standard sphenoid wing meningioma. We've noticed that some of these tumors, you get vidia nerve here in V2, a lot of these grow in the floor and into the sphenoid sinus, into the infratemporal fossa. So extensive surgery for her. We adopted an OZ in order to attack the infratemporal fossa portion, the cavernous sinus portion, the orbital portion. We actually used a space that we were able to develop between V2 and you see that here between V2 and the vidia nerve to deliver the sphenoidal component rather than doing a separate intranasal operation. In the interest of time, I'll just summarize this particular case. The entire cavernous sinus, V1, V2, V3, all stippled with tumor, and a good macroscopic resection. Obviously, there's microscopic disease with perineural spread. She has an atypical meningioma with 13.8% MIB1. And so this is a woman who's 50, and so this is now, again, this is a chronic condition with an atypical meningioma. And I don't know about your practice, but this is a standard tumor that I saw a reasonable number of these in Boston and here as well. Another surgeon, subtotal resection, followed by radiation, and atypical meningioma, significant chromosomal disarray, and then had additional resections, radiations, stereotactic radiosurgery, brachytherapy, Avastin resection, and then suddenly ultimately succumbed. And I'll skip this video here, but there's only so much you can achieve in a third-time operation who's had 2 rounds of radiation or brachytherapy. You can almost suggest that surgery there is really for symptomatic control and perhaps tissue analysis. And this is really where I think the panelists and others will say that the rubber hits the road is what to do with recurrent or refractory meningiomas. If a patient says, what determines recurrence or will my tumor come back? I think it's reasonable to, and I think everyone has a different way of presenting this, but I tell them about the importance of the extent of surgery, and I tell them that that the biology matters. And rather than get into grade, which a lot of patients don't understand, just some tumors are just going to behave differently. And I think that that's still true. And I want to walk through just a number of concepts relating to this. We talked about surgery. Even Simpson, who wrote this initial, again, now somewhat controversial paper about his grading scheme, was able to acknowledge that whether in practice clinical recurrences are more likely to result from intrinsic malignancy rather than the inadequacy of surgical resection is still disputable. So even 70 years ago, 60 years ago, it was recognized that some tumors are not as amenable to resection and are more malignant in their behavior rather than, frankly, pathologically malignant. So let's talk a little bit about how we think about meningioma from that standpoint. And we showed Cushing's grading scheme briefly. And every several years, the World Health Organization reclassifies these. Interestingly, unlike many other tumors that all of us deal with today, As you know, World Health Organization does not incorporate any molecular data in the current grading scheme. And why is that? Well, the molecular landscape wasn't complete enough, probably during the most recent annotation in 2016. And there's no robust clinical data to correlate what molecular findings were had been described at that time. So we're still left with grade 1, grade 2, grade 3. And most centers outside of leading academic centers still use that same, you get a grade, probably maybe a KS67 or a MIB1. But as all of us have appreciated at this point, it's very broad. Just take a look at the grading scheme. Even grade 1, you can have 0 mitoses or 3 less than 4 mitoses, and it still be a grade 1. And obviously, those aren't going to behave similarly. If you have 0 atypical features or 2 atypical features, you're still a grade 1, but those also don't behave the same. And that's been shown by Hellenstein and others. The addition of each additional atypical features in a pathology report confers a separate and discrete risk of recurrence. So those aren't the same, even though they're thin. And a grade 2 is even worse and even broader. You can have between 4 and 19 mitoses and be a grade 2. And again, you can have 3 atypical features, you can have 5 and still be a grade 2. So I think very, very broad grading scheme and a real cornucopia of histologically equivalent tumors at this point. So clearly other predictive factors are in play. And I think one of the incredible developments in the last, I would say, 7 to 8 years has been not so much the weaponry that we have to deal with meningioma, in addition to surgery and radiation, which we'll touch on, really is what we are able to discern and extract from tumors. And so, you know, what's contemporary right now? Well, theoretically, with radiomics, we can determine tumor biologic features before doing anything. So rather than a standard pathology report, this isn't prime time in most institutions, but you can use advanced radiomic techniques and ascertain biologic information about meningioma now. You know, we're already doing it at some centers with things not exactly radiomics, but using advanced imaging to extract biologic information like 2HG spectroscopy and IDH1 mutant glioma. And you know, Dan Cale and others have written a lot about implementing this in standard workflow. I want to touch on another biologic point as we think about the development of meningioma, and which has been so abandoned, which was, you know, it wasn't that long ago that I was in medical school, but it was red hot to think about how meningioma is governed by differences in steroid receptor expression. And why is that? Well, grade 1 is more common in women, and tumor behavior changes in different points of hormonal milieu alterations. And so that led to thousands and thousands of papers looking for ER receptor, PR receptor, androgen receptor, et cetera, et cetera. And that basically died completely with a negative RE486 trial. And you really haven't heard anything about steroid receptors and steroid biology in meningiomas for decades. And this was substantiated and backed up by a more recent SWOG S9005 trial, another negative trial showing that mifepristone was not efficacious in managing meningioma. But we will come back to this. It's a little bit of a case of back to the future, but this concept is very, very relevant again, and I'll get to that in a minute. Another I think important development recognized decades ago. I mean, this is a paper from Al-Mefti, but multiple papers years ago recognizing that your standard chromosomal configuration in a meningioma could look normal or could look widely abnormal. And this paper, many others, again, before advanced genomic techniques were around, even recognized that as meningiomas progress, if they advance in grade, if they recur, if they're more aggressive, they look cytogenetically abnormal. And so we now have an understanding, and this is work from not only our group, but Dr. Ganel, Dr. Malter, and many others have published similar work showing your standard, what does a standard tumor cell in meningioma look like compared to a cell in the germline or rest of the body. And so as you increase in grade, you have this increase in spectrum and frequency of typically regions of chromosomal loss, not so much gain, and I would highlight, if you're getting this in your pathology report, the loss of 1p is a particularly a negative prognostic factor. And we at our center, we have chromosomal microarray information on every meningioma that we remove. And as you increase in grade, this is a larger number of samples, but red being regions of gain, blue loss. High-grade meningiomas, grade 2s and 3s have just a much more chaotic genomic landscape from a chromosomal array standpoint. And so to this standard grade, there's beginning to be added some additional descriptive information, and I'll show a little bit later near the end that really has significant natural history applications. So we'll talk about mutations in a minute, but Dr. Malturno and Dr. Gunnell's groups have specifically not only described a number of these canonical mutations, but also just very recently how important they are for molecular subtyping in their natural history. But the grade to the histologic grade is also being added, this increasing spectrum of a copy number alterations. And so, not uncommonly, we'll get a pathology report, grade 1 meningioma, and then 7 days later, we'll get a report like this. So grade 1 meningioma, maybe the MIB1 is 1.5%, but then you'll get 2 weeks later this copy number alteration report with a loss of 1p and 22q consistent with a grade 2 meningioma. So is this the real fingerprint of a meningioma? Less so, how it appears on the surface histologically, and what is the relationship between histopathology and what the world is still receiving with a path report and a copy number profile, which is an example of probably what is more representative of the true biology behavior of a meningioma. And A.L. Eisner, great radiation oncologist at Dana-Farber, published a very nice paper a few years ago validating that just the number, arithmetic number, not a fancy algorithm, but just an additive number of chromosomal alterations. The more you have, the more likely you are to recur, independent of what your resection is like and actually the grade of the tumor. So there's some biological relevance to that information. And so just an example, this is two atypical meningiomas I resected within a few months of each other in standard pathology reports. They're both grade 2s. One has a MIB1 of 2 to 3%. One is 7%. Okay. One has some swelling. They both have a little swelling. One has monosomy MIB22, standard grade 1 meningioma profile, and one has 1p 14q22 loss. So the histology, not that different, although MIB1's a little higher. The chromosomal profile, these are wildly different tumors, and it may influence whether or not you add radiation or not. So I think a take-home for that work is that multiple chromosomal alterations associated with aggressive behavior and recurrence in meningioma. I want to summarize another really important movement in the last 5 to 6 years, which has been the description of the mutational landscape in these tumors. And again, work from the Yale group and our group and others. And now we have an understanding, and there's really every month an additional recurrent mutation identified, either gain or either deletion or gain of function. But I think what's been therapeutically most relevant has been the identification of smooth-end and AKT1 mutations, and most of you are familiar with the trial that's based on those. But conceptually, too, I think it's important to understand that you've got NF2 altered tumors and you've got NF2 wild-type tumors. So in the NF2 wild-type tumors, you have this overlapping spectrum of mutations. And I think what we're seeing now is an attempt to apply that information and in what is a classical precision medicine approach. So this is a paper from a few years ago using an AKT1 inhibitor in an AKT1 altered tumor, and you can see these are growth curves at the bottom. Not so much regression, but stability of disease in an AKT1 inhibited tumor with an AKT1 genotype, mutant genotype. And you're seeing an increase in proliferation of reports similarly. So a number of these pathways activate the mTOR pathway, and so you see the use of implementation in clinical trials using everolimus and the recognition that the KLF4 mutation that often occurs with TRAF7 also perhaps activates the mTOR pathway, and could that, and at least in an animal model, could that be therapeutic? So, and the last example I'm showing here is a PI3 kinase inhibitor trial, of the Ultram trial in progressive refractory meningioma. So a classic precision medicine approach for meningioma. And again, I want to highlight the Alliance trial in recurrent or progressive meningiomas that are genotyped either smooth and AKT1. And it turns out NF2 mutant tumors may respond to an FAK inhibitor. So again, your classic precision medicine approach to meningioma. And this is pretty recent work, and perhaps Dr. Malatura could expand on this because this is from a really nice work from her. Is this mutational information? It's not just this alphabet soup you're going to get anymore. It actually has meaningful, not only therapeutic relevance, but natural history relevance. So she's really been the first to show that the harboring these specific mutations actually has behavioral, defines and bends these tumors into behavioral subgroups. And again, I'll let her expand on that. But head shock, you can see on the left, I like this figure on the left, top left here, time to recurrence. If you're a head shock mutated or smooth mutated tumor, more likely to recur. And I think that's really adds some behavioral relevance to mutational profiling. And that's, in addition, and consistent with Calamarides' work showing that a smooth and mutated olfactory group meningioma, same grade, is more likely to recur than a smooth and wild type tumor. And so there's translational therapeutic relevance to mutational profiling, as well as natural history and prognostic information. So if we're to just highlight some take-home messages from all of this work, it's that they're targetable mutations, they're actually mainly in grade 1 meningioma. But those tumors that have AKT1 and smooth, they're actually often resectable, and those mutations are relatively rare overall. And I think excitingly, Jennifer's work has shown that this profiling really defines behavioral subgroups in these tumors. It would be ideal if there were great targetable mutations in higher grade meningiomas, but that is not the case currently. And you can see all of any targetable mutation typically occurs in a grade 1 tumor and not a grade, not a higher grade tumor. But again, introducing another theme, how could we ascertain that information, and how could that inform clinical paradigms going forward? Well, maybe we could identify these through ctDNA or circulating DNA, and can you identify these mutations before intervention, and could that influence a neoadjuvant paradigm? And there's a couple of recent reports showing actually identification of tumor-associated mutations in the bloodstream. So very early, but nevertheless exciting. You can imagine how that could be applied going forward. And this is an example of how that could look. If you think about the craniopharyngioma landscape right now, and that's obviously been turned on its head in the last few years with the identification of, in particular, the BRAF mutation in nearly 100% of papillary tumors, and that's been the foundation of this of inhibiting the BRAF, implementing BRAF inhibitors in these tumors. But look closely at one of the cohorts here. You could, to be part of the newly diagnosed arm, you have to have measurable disease and biopsy-proven papillary craniopharyngioma. So you can enroll in this trial with actually out of resection. You could just have a biopsy. So what about a non-invasive biopsy? You could see how that could be applied to meningioma in the coming years. And I think it's important for everyone to also understand that some mutations are not targetable, but they're just as Dr. Malaturno has shown in grade 1 landscape, some of them these predict aggressive behavior to a TERT mutation, either at the time of resection or as it emerges during progression, BAP1 loss or loss of CDKN2A or B is very negatively correlated with outcome. Unfortunately, mutations change from primary tumor to recurrence. So this is just a plot showing mutations shared between subsequent resections. You can see a very low percentage of mutations present in one meningioma resection appear in the same tumor that recurs. And this is just a standardized way of an algorithmic way of showing a phylogenetic relationship in a tumor that was serially removed and radiated. The same sorts of interventions that happen in higher grade meningiomas. And you can see S refers to a surgery. These mutational profiles really bear no resemblance, and there's no orderly way that they appear, and essentially a random ordering. So these mutations in meningioma vary over time. Interestingly, the higher the grade, the more these tumors also feature elevated mutation burden, and not only that, but meningiomas with increasing grade also express increased number of immunoregulatory molecules, specifically PD-L1. So if you combine elevated tumor mutational burden in a higher grade tumor and the fact that that some of these tumors with increasing grade express checkpoint proteins rather, you can understand that a number of folks are beginning to look at phase 2 trials of Nivo or Pembro in these tumors. We reported on a successful response to Nivo in one particular patient who happened to have mismatch repair and a CDKN2A loss, but by and large, other patients haven't had a similar response to this this approach. But so I would say, to summarize, higher grade meningiomas don't generally harbor targetable mutations, although those are tumors you would hope would. But I want to emphasize that's only as identified through genomic sequence. That does not mean there are not transcriptional programs or that are in play, and I'll get to that in a second. And just as in oncology, tumor mutational burden, PD-L1 expression, the same concepts that are applied in malignant disease may also be relevant in select difficult to treat meningiomas. Just a word on radiation. It's really a separate talk entirely, but as we think about biology and what is the role of radiation in meningioma, obviously either as a standalone or as adjuvant. Me personally, I always use it in grade 3 tumors. And I personally, although it's not validated, I would not certainly use this as dogma, do use copy number profile to help influence whether or not I apply radiation in a completely resected grade 2 a tumor. But just to highlight some really exciting trials will come out. R2GO539 and BDN003 will help really address the question of what's the role of radiation in a completely resected grade 2 tumor. Rome is the European version of that, but I would highlight work from Albert Kim at WashU, which is really started to get at what predicts response to radiation. That's a very poorly understood concept in meningioma. We still, again, just use grade to guide that, but and Albert helped describe that spontaneous necrosis is a negative predictor for response to radiation. But we really have very little in the way of information that predicts really healthy and durable response to radiation. So obviously, just as with targetable treatment, it's a very precise tool, but its exact indications across grades, I think it's fair to say, are not totally understood and are somewhat imprecise at this point. Just in the last few minutes, I want to highlight work from a number of groups that I think is probably the hottest type of work in meningioma right now, which is that all of this molecular information is going to completely change the way we think about who responds to treatment and how you will do long term. And so while now we rely on World Health Organization grade, this is an example of Akash Patel's work. This is RNA-seq data, bulk RNA-seq data showing that groups as bin by RNA-seq data, it's actually do fall into clinically relevant groups, and it's actually it's more relevant and more accurate in predicting recurrence than World Health Organization grade. This is work driven right now by Joe Driver and Linda B at the Brigham, but using what we spoke about before, very easily it's scalable information, copy number profiling in MIB1 to bin patients into high-risk groups. Again, they've also gone on to show that it's more accurate when compared to World Health Organization grading to predict overall survival and recurrence. So you're seeing an emergence of a large number of groups using advanced genomic, and I'll get to it in a minute, epigenomic information that is more accurate than World Health Organization in predicting outcome in meningioma. This amalgamating copy number profile in MIB1 from Joe Driver and Linda B's work. This is standard grade 1, 2, and 3 on the left. You can see when you account for copy number profile, large number of grade 1 tumors and a not insignificant number of tumors begin to sort of bin into a more aggressive molecular cohort. So, and there are a number of other examples of this from other groups where a deeper molecular annotation may help explain why we see benign appearing and benign acting grade 2 tumors and very aggressive appearing and acting grade 1 tumors. Molecularly, they aren't really grade 1 or grade 2, respectively. We've spent a lot of time talking about genomic work, but I think work from Felix Sam and Gelleray and Farshad has really shined a light on the importance and power of epigenomic classification of meningioma. And this is, I would highlight again, mainly these two papers and you can see from the SOM group here, 3 positively behaving and benign behaving meningioma cohorts as clustered by methylation, and 3 very poorly acting meningioma classes as structured by methylation data. One comment, methylation is a little bit less easy to scale at this point, but very powerful in predicting behavior. We talked a little bit about biology in the steroid receptor expression before, and how really no one gives a talk on this, has given a talk on this in 20 years. Calamarides in France actually sequenced a cohort of women with grade 1 meningiomas exposed to progesterone agonists and compared that to historical controls. And very interestingly, they had 11 times the incidence of PI3 kinase mutations in progestin-associated meningiomas than with historical controls. And so that was really one of the first papers associated with progesterone or estrogen or any steroid in many years. And what's interesting is this is work from David Rowley and Jeremy Rich, very recent work. Again, epigenomic clustering, they actually characterized the super enhancer landscape in a number of, I think, over 30 meningiomas. And I'm not going to summarize all of their work, but interestingly, 3 main groups emerged, and they had specific transcriptional signatures related to progesterone and androgen. So I think what's old might be new again, and we might be talking about progesterone as we haven't spoken about it for many years. But what's interesting about this work and the methylation work is you don't have to have a mutation to have a target. You can profile transcriptional networks, and this work and others have shown that epigenomic classification can suggest therapeutic targets just like mutational profiling can. Like some of the earlier slides I showed, they've also gone on to show that this enhancer clustering is correlated with clinical outcomes. All that to say, many institutions are still just reporting this grade and a possible MIB1 or Ki67. But if you think about it, this is what the future may look like for meningioma, as with many other tumors. This is how it looks now. We have an MRI, we decide to observe or intervene. We get a pathology report, and we determine that, which helps us understand if that's a high or low risk for recurrence, and we use that to inform our adjuvant therapy. But going forward, can we ascertain increasing amounts of information before surgery or before intervention? Genomic information is ascertained in serum, radiomic information for grade and behavior. Could that inform non-invasive or neoadjuvant treatment? If surgery is obtained to a standard pathology report, we're going to see just an increasing laundry list of genomic information, epigenomic information, RNA-seq, and immune profiling, and certainly others that will help us understand not only how these behave, whether or not they may respond to radiation or other adjuvant treatments, and perhaps inform not only mutational targets, but transcriptional networks that are in play that can be targeted, immune profiles that would suggest response to immunotherapy, and those will have significant bearing on clinical outcomes, and that cycle may repeat again and again. But I would say, despite how incredible this revolution in our understanding of meningioma is, I still would suggest that we don't lose sight of still what is our most potent weapon in handling this disease, which is aggressive surgery. Thank you.
Ian, that was phenomenal. Thank you so much for the really complete and very thorough review. Do you think that we're going down a line where when people recur, we would need to then rebiopsy at that time to kind of understand what one of these possible targets may work for that patient, and not
I think
old
that's a great question. I think even before that, I mean, you could make not that you want to twist somebody's arm, but if you're thinking about, let's say, before the recurrence, the initial resection, initial diagnosis, and you're entertaining, or the patient's asking about radiation versus surgery, I think you could possibly make the case that obtaining pathologic information might move that needle. All things being equal, if you could do surgery safely. And let's say it's an older patient who's asked about radiation. I think even in the non-recurrent de novo setting, having that biological pathological information probably is meaningful now.
And then, there are a lot of, I know you're kind of trained in a way, very aggressive surgery is the first way to go. And that's kind of what we go here. But there's a lot of other people that kind of are more fans of adaptive hybrid surgery, and especially for these tough skull-based tumors. Do you think that, perhaps knowing the molecular transformation of these tumors, if you did a kind of a lesser surgery, then perhaps going back in these cases where you know that radiation is just not going to be effective or not going to be enough in those cases, and therefore the risk of the extra whatever percentage of tumor is now worth it?
Great question. I showed a case of a subtotally resected tumor that occluded the sinus, operated on at another institution for a reason, which is, the shame there was that sinus was occluded. So if you're going to operate in the sagittal sinus, what better tumor to operate on than one where there's no flow in the sinus? But that patient ended up dealing with this residual tumor for, look, the biology may have influenced this outcome, but certainly I think adaptive hybrid is certainly often discussed. I just think we know what's effective in dealing with tumor that's with remnants or with recurrence. We know what radiation can do. We know what all this molecular profiling is. It's exciting, but it's not currently ready for prime time. And so there's not anything else that we really have that's highly effective other than surgery. So, I think you can be aggressive but careful, and aggressive but appropriate. And I still think playing for a draw and playing for win still are different psychologically. And I think especially as we're training and as we're refining our surgical technique, I do think, again, you can be careful. We want to leave patients functionally, and we want to leave. We don't want to have complications. So I'm not advocating that, but you can still be aggressive and sensible at the same time, and and have a goal of a complete resection, even if you may not achieve it.
Sure. Fantastic. Jennifer, do you want to kind of get to your case?
Sure, happy to. Can you see that?
Yeah, looks good, thanks.
So first, I want to say thank you for the invitation. It's really a pleasure to be here. That was really outstanding, Ian. Of course, highlighting your beautiful work, but also summarizing everything about meningiomas and the way we treat them. And I couldn't agree more with your approach for surgery, as well as your rationale and thoughts of precision medicine really being structured around the surgery. That's incredibly important. And then I, like you, tend to be very aggressive with surgery and really try to stay away from radiation up front, at least as much as I can. My disclosure is that I saw the email that said limit to 5 to 7 slides like 20 minutes ago. So I have about 20 slides. So I will go really, really quick, I promise. Okay, so and a lot of this has been touched upon by Ian, but really the question is, does the underlying tumor biology play a role in the management with regards to extensive resection, clinical behavior, recurrence, and survival? And of course, we learned from him, of course it does. The question that I always ask people is there really a such thing as a benign meningioma? And I think we're finding out more and more that in my mind, there really is not. This is a patient who was referred to me. He was operated on prior to 2017 at an outside hospital, very similar to like what Ian had presented. He had some tumor that was left behind. This is convexity, obviously, where you would think you would be able to get a nice margin around the tumor. I don't have the initial scan here. He presented then in 2017 with some growth. He had been told this was a benign grade 1 meningioma, just follow it, no big deal. And then it grew. And in 2017, which you see the scan here, he then got several different opinions for surgery, for radiosurgery. He went with radiosurgery because it was easier, outpatient procedure, safer. He ended up having a number of complications related. And when he presented to me, in 2019, he was wheelchair bound. He was seizing with difficulty to control his seizures and really profound weakness. And so the question that I had, I resected the tumor. He actually did beautifully despite all of his comorbidities, but could this have been predicted or managed differently the first time? Similarly, this is another patient, young guy, who I don't have his initial pre-op. This was his post-op, where you can see there's been some changes near the frontal sinus and a craniotomy defect. He was similarly told this was a WHO grade 1 benign meningioma, and just follow up as needed. And then that neurosurgeon called me when he presented 2 years later with this scan. And so sent him over to me, and then we resected the tumor. That's actually some abdominal muscle as a flap to prevent spinal fluid leak by my talented colleague, Mike Alperovich of Plastics and Reconstructive, and Ben Judson from ENT. And so could this have been managed differently the first time? And so as Ian mentioned, we really have a better understanding of the genomic landscape of meningiomas thanks to his group and of course our group at Yale. The basic science that I'm describing has really been done by Murat Genel in his lab at Yale for the last decade and more with regards to meningiomas. The part that I have been adding more recently is the clinical correlations of what we see. And so the Genel lab, as well as others, as Ian has so nicely shown, really has offered the understanding for somatic genomic landscape of about 80% of grade 1 meningiomas. And of course, we have these subgroups that Ian spoke of. And this work was really done and performed by Victoria Clark, who's down here, who's currently a resident at MGH. Furthermore, I actually had published a paper when I was a fellow at Memorial looking at the fact that patients with more malignant types of tumors, meningiomas, could present either de novo or they could progress from low grade to high grade. And Murat in the lab actually found out the biology between this, underlying this rather. And so these tumors tend to be NF2 mutated, these more aggressive types of tumors. And then they can progress to higher grade tumors by either chromosomal instability or by SMARCB1 co-mutation. This is different than those tumors that harbor promoter mutations that are usually de novo atypical meningiomas. And so more recently, with work that Mark Youngblood here, who's actually a resident at Northwestern, has done, looking at about 500 meningiomas, and Ian actually showed this figure, which was one of my favorite from the paper that was recently published, showing that the meningioma subgroups really do correlate with overall rate of recurrence. And so here we found that there was a divergent clinical course at about 2 years follow-up. And so there's aggressive subgroups, and those typically are NF2, tumors with mutations in NF2, the PI3 kinase pathway, hedgehog, and TRAF7. And these tumors tend to recur at an average of about 22 times higher than others. And this is for grade 1 meningiomas as well. We also found that there tended to be ones that were less aggressive. And so KLF4 mutated tumors typically behaved much more quiescent compared to the others. What was interesting At 60 months, hedgehog mutated tumors, NF2 and TRAF7 mutated tumors all exhibited elevated recurrence, but those tumors that had mutations in the PI3 kinase molecules recurred earlier, and they recurred typically less than 2 years. And so this was really the first study that identified these molecular subgroups to have an independent predictor of recurrence, along with grade and prior recurrence. And so we tend to use this clinically. I use this clinically in my practice all the time. Back in the 2013 Science paper that was published, we understood the location along the skull and how the genomic subgroups related. And then in a more recent publication last year in Journal of Neurosurgery, we expanded upon this. And so just briefly talking about NF2 mutated tumors tend to be more lateral along the convexity. They really only occur anterior to the coronal suture when they're co-mutated with SMARCB1. The other tumors tend to straddle the sphenoid wing, and we've been doing more work investigating that now with the PI3 kinase mutated tumors, as well as the TRAF and KLF4s. And so going back to this patient who had presented and then underwent SRS, could that have been predicted? And the answer is yes. And so this is what we typically see and do at Yale. So we're fortunate that all of our tumors, all of our brain tumors undergo whole exome sequencing. This was his report from his recurrent tumor that I had resected. But it showed that this was a grade 2 meningioma, and it really showed that there was NF2 mutation, as well as the chromosome 22 loss, and as well as chromosomal instability. And so this is what leads us to believe that this was likely atypical from the beginning, and also owes to the fact that neuropathology expertise really is important. This was a patient, this is Balent Omai, one of our brain tumor surgeons at Yale, who I had initially helped on the original surgery back in 2017. Balent wasn't managing at the time, another neurosurgeon was. There was a very small residual that had been left near her optic nerve in her sella to preserve function. And then this, you can see, in 2018 of January, again, a small residual grade 1 meningioma. And then this is her a few months later in June of 2018. This is her most recent follow-up, and Balent has actually assumed her care in October 2020. She ended up having radiation after this 2018 recurrence. And so how do you explain this grade 1 meningioma? And he had re-resected her in October this year. And so this is her analysis looking at the old and then the original rather, and then the recurrence. And so it shows an AKT1 mutation. And so similar to what we found in the neuro-oncology paper recently, that these tumors tend to behave more aggressively. And even when they're WHO grade 1, they tend to behave more aggressively and they recur sooner. And so these are the ones that I tend to, I lead our multidisciplinary tumor board and our precision brain tumor board. And we really do use the genomics in terms of, is this somebody that we might want to radiate sooner or keep a closer eye on? And then there's more to come with that. This is another patient who, similarly, young woman, back in 2006, presented with some vision loss, had a small tumor for which she underwent a supraorbital approach. I don't have, these are not those films. It recurred in 2006. She underwent SRS, then additional radiation, additional repeat surgery, another repeat surgery. This is by other surgeons. She went to Priscilla Brastianos and began in the Pembro trial in 2019, and she failed in 2020. And so Priscilla kindly sent her to me, and you can see here, so when she showed up to me, she had this large tumor that just continued to grow with, of course, all the vasculature involved. So again, agreeing with what Ian was saying about aggressive surgical resection, she actually did remarkably well after surgery. We got a good resection. And here, this is her recurrent tumor. And so grade 1, again, despite 3 surgeries, radiation, failure of a clinical trial, and that AKT1 missense mutation. And then, of course, the chromosomal instability that she has in the chromosome 1p deletion. And so this was a patient who presented to me recently. He actually had 2 meningiomas. As you can see, I ended up taking out the left one because of the edema that was associated. And so his, that's his post-op scan there. So a nice resection, and that's his anatomy as well. But again, whole exome sequencing. And so we found he has an AKT1 mutation. And so what to do with him? Do we radiate sooner? Do we, follow him closer, knowing that we're more concerned about that subgroup? And that's how we approach these things, which again goes back to our algorithm, as many others, in terms of precision brain tumor care. Again, being aggressive with surgery is incredibly important. And we find often that with these patients who have these aggressive grade 1s or these grade 2s and grades 3s that keep coming back, it's oftentimes the surgeons that get more and more aggressive each time. But then what to follow it up with, and whether that's radiation or drugs, we certainly need more answers there. And so that's basically the summary. In my opinion, I really don't think there is a such thing as a benign meningioma. Of course, there are some of those that we can resect and get a good margin around. But in my experience, which could be skewed, they tend to get more complicated, or they can get more complicated. Can't just rely on histology. And I think that really underscores the importance of seeking care at academic centers such as the ones that we're from, and understanding the genomics, epigenomics is critical, and more work and more trials are needed. And that's it. Thank you.
Thanks so much, Jennifer. A quick question for both you and Ian. A lot of the mutations that you showed, especially in the figures, were superior tumors of the skull base and convexity, but not a lot on kind of the posterior fossa and petroclival tumors. In those cases, I think there's a lot of them that we see where they present incidentally, older age, and you just watch them and they almost have this saltatory growth period. Is there any kind of indications on any of the genetic findings as to why some of those and petroclivals or the clival or Petrus tumors, they at a certain older age, they kind of just stabilize?
So from my perspective, from understanding the genomic subgroup, some of those, at least the ones that I've looked at, tend to be to have mutation in polar 2A. And from what we have found from clinical correlations, those tend to be slower in terms of recurrence. They can still have some recurrence that we found, but they tend to be much less when compared to the other groups.
Mike, again, just to reference kind of an old school concept, in residency, you'd often hear, well, postmenopausal patients, maybe these tumors will burn out. And first of all, I think anybody treating meningiomas has seen that. And now there might be a biological rationale for that. I think the Raleigh and Rich's work and Colin Reedy's have really shined a light again on the fact that progesterone and androgens may be relevant again in meningioma. So it are variations in those programs in play in growth also.
Well, thank you both for that outstanding work. I mean, I think it's really been the highlight of meningioma treatment in the last decade. So I appreciate you guys both being here. Stephen, do you want to go with your talk?
Yeah, can you see my screen?
Yes.
Okay, perfect. Thanks for inviting me. I couldn't agree more with Dr. Dunn and Ganell, and it's a beautiful overlay of the landscape and the literature. And I also got the 5-slide thing, so I'll go a little quickly here this afternoon. But I just had a couple things I wanted to share. A similar type of case, let me see here. There we go. I have no disclosures. So the case I wanted to start with is a 20-year-old woman who had a Petroclival meningioma, one of the big invasive ones, resected via a retrosig. It was pathology grade 1, much like the stories that we've heard here. And she was lost to follow-up and then presents 12 years later with seizures, and they get a scan, and she now has this tumor that has, this is when we first met her, had this small recurrence here in the posterior fossa, as well as some middle fossa, and there's some cavernous and more middle fossa than other slices. So she was taken to the OR, and we were able to get out the middle fossa component, but the posterior fossa component was really intertwined around the fourth nerve. She was intact, and we wanted to keep her that way. So to preserve function, they left that and then followed closely. The pathology, though, because there was a residual, Ki67 was 4%, and they did adjuvant fractionated radiotherapy and kept falling for 3 years. So now, just summarizing where we're at, we've got a 35-year-old woman who's had 2 surgeries and radiotherapy and is being followed. And 3 years later, which we can see here, the posterior fossa, this small component, is totally stable. This was the MRI on the right from radiation planning, the MRI on the left. No change really in 3 years. But if we look at the cavernous component, you can see it was like this on the radiation planning with big carotids. Now it's narrowing the carotids, the tumor's more bulky, and it's started to come out here. And she's clinically worse with worsening trigeminal neuralgia. And the question is, what do you do? And I think addressing some of the other things that came up, when we looked at our recurrent meningiomas at UCSF, 20% of the tumors, when they recur, are at a higher grade. So if they were grade 1 before, now they're grade 2 or grade 3. So I think getting pathology is valuable. And because she was symptomatic, she was taken to the operating room here, and they got into it, but in the cavernous sinus, it was fibrous. It was very difficult, much like Dr. Dunn mentioned in his talk, in limiting the extent of resection. But they were able to get some of the middle fossa component, and they got biology, which I think is really important, because now this benign grade 1 tumor is a Ki67 of 20% grade 2, and you're already radiated. And so the question is, like, what do you do in these types of recurrent cases? So here we don't have it, I don't think, in-house at Ohio State, but they send out for the Tempest panel. And her tumor she was discovered new information for her to be BRCA1 germline. And then she had an AKT1 mutation in NF2. So we said, well, let's see what happens. And so they got a short interval scan. This was our post-op scan here. 3 months post-op, we got a whole big bubble starting to come out into the middle fossa. And she's got some mild ptosis. So now you've got a lady who's had 3 surgeries, radiation, you've got a bad pathology, and given the BRCA1 mutation, we consulted neuro-oncology at our precision medicine board, and they said, hey, let's trial a PARP inhibitor. PARP inhibitors are approved for BRCA-mutated tumors, which for breast, ovarian, and pancreatic, but not meningioma. And they're thought to work by allowing the BRCA1 cells are dependent on PARP for DNA repair. So if you inhibit that, then they end up undergoing apoptosis. So we trialed her on olaparib, and 3 months, this was her post-op scan, 3 months or 8 weeks of olaparib, and nothing is going on except the tumor's growing really bad. In just 2 months, you see that kind of growth. And her third nerve palsy is now worsening. So I was involved in this surgery. This was just a few weeks ago. A couple months ago, we did a middle fossa approach, peeled the middle fossa. We were able to get a bunch of the cavernous sinus component and this lateral middle component out. And her third nerve improved, but that's not going to be as good as the best we can do surgically is not going to be good enough for a tumor like this. So 4 surgeries now, radiation, worsening trigeminal neuralgia, still grade 2, and with now some focal rhabdoid features, and she's failed the BRCA1 treatment. So we got a scan 1 month post-op, and I don't know if you guys have ever seen this, but there was some necrosis of the residual within the cavernous sinus. And I also want to point out that that posterior fossa component stayed the same. The rest of the tumor was blowing up, but that stayed the same. So now we've sent her over to Northwestern, where she's going to start this mTORC inhibitor trial with vistuserib. And that, just as a reminder, the PI3 kinase pathway signals through AKT and mTORC. So by inhibiting mTORC 1 and 2, hopefully that may help her, but it's still terrible for a 36-year-old that has this really aggressive tumor. And I had a lot of questions. I know we're getting a little late, so maybe I won't go into them. But I think the one I wanted to highlight, and before I talk just a couple slides of research, was, and maybe we can chat about later, is what we should do when we do these kind of like attempted treatments. How should we as a field start to report this to each other? Because this is data that we're not really collecting because it's not in a trial. I think getting people in trials or having adaptive trials or something is really important. But what I wanted to talk just a couple slides scientifically is one of the things that's really interesting about this tumor is this little posterior fossa component that was radiated has been fine and had no problems, but something different went on in the middle fossa part that expanded. And we know that intratumoral heterogeneity can lead, is a known mechanism of tumor resistance, but we didn't know much about that until recently in meningioma. So we just published this fall the work I did during residency, where we sampled from 13 different tumors, 86 total different sites. All were along the midline, parasagittal folks and convexity, and then did RNA sequencing and DNA methylation profiling. And we saw that the higher grade tumors, each site is represented by a dot, each color is a tumor, and the lower grade tumors had less variability in their transcriptomes, which is what's shown here in principal component analysis compared to high grade tumors. But there certainly was heterogeneity, and that increased with high grade tumors. We also, by looking at different sites within the tumor, could reconstruct phylogenies. And so this is based on copy number variants, much like what Linda's work is showing and Ian's work. 1P was mutated in this grade 3 meningioma, but then if we look at the different sites within the same tumor down each arm, we found different gains and losses within the same tumor. So this chromosomal instability that we see is something that's dynamic and ongoing within individual tumors. It's not like just, well, some meningiomas get to a certain point. Several of the tumors in the study were grade 1, and they had much simpler phylogenies. This one just had 22q loss. Others might have one site that was different, but tend to be more clonal. And when we looked at the heterogeneity, we also noticed there was radiographic heterogeneity. And so we found that there was more heterogeneity in the ADC signal in higher grade tumors as well. And so since we had molecular data, we wanted to correlate that. And when we looked at regions that had high ADC signal, we found that they were more likely to have increased proliferation. And when we looked at gene expression changes, we found an increase in cadherin-2 expression in those transcripts, suggesting that maybe high ADC areas within the tumor are regions with greater proliferation. We then developed a meningioma model for studying this, like how can we do this? So this is live cell imaging over 36 hours of grade 1 meningioma cells in red co-cultured with organoids, and grade 3 meningioma cells in red in this side. And the grade 1 meningioma cells go around cerebral organoids and form little tumor balls, but the grade 3 cells actually, they form the spheres and then they actually invade into the organoid itself. And when we did single cell sequencing on that and looked to see which cell populations increased within the co-cultured organoids compared to meningioma cells cultured alone versus those that were cultured with the organoids, we saw expansion of this cadherin-2 population. So we then used a CRISPR small guide RNA in this model system, and what you can see looking at the percentage growth, which is in this line, if you use a non-targeted control, you can see that the cells with a knockdown of cadherin-2 don't proliferate. And if we look at a longer term time point using inhibitor of cadherin-2, ADH1, those also had decreased growth compared to the control. So just a quick summary of our paper, but there is heterogeneity in meningioma, and I think the heterogeneity within the tumor may be one mechanism that these bad tumors are using to escape this. And the genomic instability that we see is something that's dynamic within the tumor. And then we identified cadherin-2 in this novel organoid model for testing things. So I really, these cases, I think of a lot of both of the ones that you both have presented, and it's a nightmare of what to do for these patients. I think the best surgery up front is absolutely the most important, and getting as much as we can, but then, we desperately need new therapies. And I think as a field, when we're getting more, especially within the academic communities, some of these molecular tumor boards where we trial things, I don't know how we should develop a clearinghouse or something to report these cases, you know, and then ultimately amalgamate them, say, hey, this was a BRCA1 mutated tumor and we trialed olaparib and it didn't work, you know. And you showed the same thing, I think, with the Pembro trial, you know, a patient who tried that and then failed after a year. So
Thanks, Stephen, for adding a whole other level of complexity. But no, but great.
If I can make a quick comment, Mike, that was great talk from Dr. Militano and Dr. Brigill. You know, with that patient you showed, you kind of also wonder, you know, what is there a role for, let's say that was just cavernous sinus generally. Is there a role for cavernous sinus exoneration?
Yeah, and bypass, but can you get it all, you know? And that's the question, like, is the biology, like, could you actually get all the tumor enough that it would not come back with the biology? And, you know,
I think the thing in those cases, I think we know how most of those trials will turn out at this point in 2020. And so, yeah. You know, is there a role for her? I mean, that was surgery in the 80s, right? Was heroic cavernous sinus exoneration. That propelled this anti-skull base movement for 20 years, right? Was this overly aggressive surgery? But is there a role for that in the case that you showed? And I'd argue with any young patient, if there's nothing left to do really, and you've gone through a number of trials, it's not totally unreasonable.
I think maybe down the road for her, the thing that I'm worried about is, you know, she still has great function in that eye. So to take somebody's eye, like, you know, that's a pretty drastic thing. I don't know if
I'm not that sure to this case so much as the concept of if you failed A, B, C, D, and you're now flying around the country for things that are, you know, less and less hopeful, you know, is there a role for that?
Yeah, well, point is, are these benign lesions now considered cancer, and the whole strategy kind of changes there to you know, life-saving versus quality of life-saving, and that's a tough decision. And you know, BTO bypass, we could have a whole hour discussion on cavernous sinus exoneration and lessons learned. But yeah, my question was the same thing though when I saw that case after the third surgery and it was still in the cavernous sinus. Stephen, was at what point would you consider exoneration? So I'm glad Ian brought that up. Okay, we're running kind of short on time. So Carolina, do you want to go real quick and then we could go with Ashish?
Yeah. Thank you guys. Those are excellent talks. I'm going to try to go real quick. Mike wanted me to sort of give a little bit of like the radiosurgery perspective and what its role is. And I think one of the most important things that this case sort of presents is that there are patients, like we've all been talking about, that you really need a multimodal approach. And certainly there is going to be a role for surgery first, and I'm on board with that. Radiosurgery can play a role, but even as we've seen in these cases, you're going to get to a point where you run out of options. And I think this is a particular case. It was, you know, this person's story started in 2013, so it's somebody that didn't get the benefit of molecular analysis, and just now I think, you know, we're starting to get around to that. And so you'll see in this case that really it would have been best if this patient had access to that sort of molecular profiling way earlier. So this gentleman, 68 years old, presented with partial motor seizures. So I'm just going to go, and this was done actually at an outside hospital in Puerto Rico. So this is just the pre-op scan. I'm going to go through pretty quickly. This is in 2013, and I don't even have the post-contrasted images for this patient because it was in Puerto Rico. So we do have the post-operative scan from them. Pathology comes back as a grade 1. Again, that's all we get. We don't get the Ki-67, MIB1, nothing. So relatively good resection, but I think we can see here that there's going to be tumor left in the sinus there, which is concerning. Although for a grade 1, you know, I agree, this is pretty good, looking pretty good so far. So, and gets observed from 2013 to 2018, again starts presenting with partial motor seizures. And you can see here, you know, recurrence of this tumor extension into the sinus. We did get a MRV, and actually I believe he also got an angiogram. It did show that the sinus was still open, albeit, you know, stenosed where the tumor was. So gets a surgery, second surgery at this point. Pretty good resection. We were able to essentially shave it up until the sinus, and as soon as we got sinus bleeding, we had to stop there. So it wasn't a complete resection as there was tumor going into the sinus, but pretty good. This time comes back as a grade 2 atypical. So having known that there's going to be some residual disease, also actually there was some residual disease in the veins leading up medially, and you can see that we dissected as much tumor as possible off of the veins, but given the location, we also didn't want to hurt the patient. So we knew we were leaving some tumor behind. At this point in 2018, I believe the Ki-67 here was 6 to 8%. And again, that's all we had in terms of profiling. So the decision at this point was made to do radiosurgery. So you can see here, this is the plan, and he got 16 grays at the 50% isodose line to this portion here in the midline towards the sinus. And then there's a little bit of a smaller component anteriorly where that vein was coming in, got 16 grays at the 70 there. So does pretty well overall, but of course recurs laterally. So I think a lot of, and this was all discussed at many tumor boards. There are certain institutions who would upfront do large field radiation. And I think there's also another concept of doing sort of SRS to the nodules, to the recurrent nodules. We tended to do, and this is actually when I was over at NYU, we tended to do more SRS to the recurrent nodules. So this patient had gotten this medial section, SRS to that. And then you can see here, this was the plan for the getting 15 grays to the 50% isodose of the lateral section there. So does pretty well, except not too much longer, just 9 months later. You can see where this story is going, just comes back. And I think at this point, having had radiation twice, having had 2 surgeries, everyone, this is not the type of patient you're eager to go in and do another surgery to, but you just have to at this point. You can't really, try to manage this minimally when this is such a big issue. And, this mass here, the patient was doing fine neurologically, but this mass here was growing pretty quickly. So there were 2 distant anterior nodules that did get radiosurgery. As you can see, this was a radiosurgery planning scan. And once we got there, we decided we're not going to do radiation to the major bulk of the tumors. We just radiated 2 small tumors distantly, anteriorly, but under recommended surgery. And he underwent repeat surgery, did very well from that. Again, got a very good resection, and this time comes back as a grade 3. So what to do? And I mean, if we had more time, we could go through and discuss, what each of the panelists, how they would manage it at your institutions. But given this patient's sort of refractory nature and how aggressive this tumor, and it just seems to be, every time he gets surgery, it gets more and more aggressive. He ended up getting radiation and was also on Avastin. And up until a year out from that, in October, the imaging has been stable. But I think the important part about this case is to show how the multimodal approach is really important. There can be a role for radiation, certainly, but you also have to recognize the ability as to when to stop and say, all right, well, this is not a good option, go back to surgery if need be. And I think this is the type of patient who initially didn't get the benefits of molecular profiling. And now that, he's had a recent surgery, he is getting that data, this third tumor, the pathology is being sent from molecular analysis. And hopefully, this is going to be a medically managed tumor, because it will continue to recur. So it's just sort of illustrates these complex tumors where you're sort of left with difficult decisions to make.
Thanks, Caroline. A tough case. Ian, any comments?
I'm glad that was your case and not mine. But for you and Dr. Benjamin and other panelists, do you ever think about brachytherapy at any stage of that management process?
We did discuss brachytherapy with him. This is somebody also was a difficult social situation. So it was discussed with him, and ultimately in our tumor boards, we sort of went against that decision, but it was brought up, and I think actually might have been a good option for him.
Yeah, I trained with Stephen with McDermott at UCSF, and for these recurrent high-grade meningiomas, he has a great series of outcomes with brachytherapy, and so
we actually also we also had a trial for some time, the Lutathera trial with the somatostatin analog. And I think, you know, some patients who really were refractory were getting some benefit out of that trial, but that was also, that's also, you know, to be determined.
Yeah, I think along the sinus, that's a good spot for brachytherapy, Mike. And like in this type of case, because you know, you can't take everything there, so leaving it would be useful, but I don't know if I'd say the results at UCSF are good, but it's something at the end. You know, it's definitely
it's something.
And so,
now,
you know, it's pretty a great question though for Ian and Jennifer. At what point are you now sending out tumors to get the entire panel? I mean, obviously, probably at your institutions, you're doing it for every meningioma, but for these patients that come back as grade 1 up front, would you encourage everybody to be sending these out to get complete molecular profiling, or not?
Yeah, I mean, we do a whole exome sequencing on every brain tumor. So we're fortunate that we have the whole exome sequenced, and again, it's every brain tumor. So we have that up front. I think, you know, yeah, that's why, you know, also in the community, a lot of times patients will see with a convexing meningioma, it's a chip shot meningioma. And so you get a lot of the community neurosurgeons who are resecting them, and not so completely sometimes, and then or this, you know, loss to follow up, it's benign, you know, and the body anatomy pathologist, you know, will call it a grade 1 meningioma, you know, and you don't have the academic neuropathology and everything. And so so I really think it underscores the fact that there's, to me, no such thing as a chip shot meningioma, because they really have the potential to become more aggressive if they're not aggressive from the start. And I think it really does benefit from an academic center.
We would echo that. We've started doing that at Oklahoma last year, so everyone gets copy number profiled, and it's not the whole exome, but it's a panel of several hundred brain tumor associated genes. But you know, the case that was just shown, Dr. Benjamin's case, you know, that tumor was malevolent from the start. You know, and I think that's one of the. I think Jennifer brought that same concept up, and I think that's one of the values. And I'm not anti-radiosurgery by any means, but and Mike brought up adaptive hybrid, and just, you know, we can be careful with surgery, but still, you know, aim for a complete resection. But certainly one of the values of surgery, in addition to symptomatic relief, and is obtaining that information, because, you know, likely that was going to do that from the beginning.
Mm-hmm.
Okay, Ashish, a little over time. Maybe we could share us your cases real quick.
Sorry, yeah, can you hear me?
Yeah, you're good now.
Good. So I'll be super quick. I'm just one of the chief residents here. Had the pleasure of training with Mike and doing some of these fun cases together. So get your opinion on a few things. I wanted to focus on radiation-induced meningiomas. It's been something kind of interesting to me. And we see quite a few of these here in Miami. This is just a 40-year-old who presented with orbital tumor as a child, got radiation about 30 years ago, presented with this kind of cavernous lesion kind of encasing the carotid. We ended up biopsying this lesion endoscopically, and it ended up being an atypical meningioma. The patient wasn't kind of interested in a big surgery or any kind of thing like that, so we ended up just watching it and then radiating the patient. We ended up radiating the patient up front because it was an atypical. And, you know, she's been stable for 4 or 5 years, but, you know, it kind of begs the question, you know, what's, you know, these radiation-induced meningiomas, we kind of have an idea that they're more aggressive than, you know, your, you know, spontaneous meningiomas. And even as a grade 2, you know, do you have to treat it more aggressively up front? You maybe do a bigger surgery, you know, potentially cavernous sinus resection in this patient who doesn't have an eye, you know, kind of begs that question kind of up front. So, I mean, you know, we ended up looking at our series of radiation-induced meningiomas at Miami, and, you know, just briefly, we noticed that the recurrence rate was, you know, quite different in the radiation-induced group compared to the, you know, spontaneous group, and that this was, you know, even controlling for, like, you know, Simpson grade and everything like that. So I guess my question is, when a patient comes in with, radiation-induced meningioma up front, do you just kind of have a predisposition to be more aggressive with surgical resection, try to reserve radiation to the last possible option? And then I'll show this next case. It's a little less exciting, but kind of just to ask you guys whether or not the level of aggression you have with radiation-induced meningiomas. I don't know, Dr. Dunn or.
Sure, that's a great case and one that I think all of us see in our practices, especially if you're attached to an academic center, the kids who have been radiated for prior cancers or earlier in life. There's been some nice work done in the last few years annotating the genetic features, alterations in radiation-induced tumors, and I think I personally have been surprised. I'd have a preconceived notion that these are going to always be more aggressive, but they aren't always. And again, there's multiple paths to a meningioma, either somatic development or an environmental cue like radiation. And I think it does come back to the science. I mean, if the features suggest a benign acting radiation-induced meningioma, I think consider it the same. But I'd say my gut impulse is still to be a little more aggressive. I think looking at this tumor here, I could, and if the patient says, "Hey, I like Dr. Ivan, but no thanks on a bigger surgery," I think you've had a great outcome here. But it would be interesting to have looked at, again, just like Dr. Benjamin's case, this tumor might have had some features that, if we knew better, would predict a better response to radiation, and maybe some features that suggested a more indolent behavior.
Right. Yeah, they didn't do the whole foundation 1 sequencing on this patient, unfortunately, just kind of atypical meningioma with like Ki-67 of like, I think 6 or 7%. But she's been stable after radiation, for 4 or 5 years, so that's been good. But I mean, just something to think about. And then this is just one more case, real briefly. It's a 49-year-old female who had, at least 2 resections of the parasagittal meningioma with radiation like 5 years ago, who now kind of comes back with this, scalp swelling, a new falcine lesion. All these lesions are kind of like, growing separately. So, the question is, getting an angiogram, MRV, we ended up getting a venogram and showed that the sinus was, kind of present proximally, but distally kind of reconstituted into these kind of 2 small dural veins. So the question, here is, how aggressive you need to be in this patient who's had multiple resections. And I think all the talks today have shown that, you need to be aggressive in treating these patients because that's their best chance. And, we ended up doing a pretty decent resection here. And we left a small amount on one of the draining veins posteriorly. The pathology showed clear cell meningioma atypical meningioma with clear cell / choroidoid features, Ki-67 of 15 to 18%. So I guess my question here is, we have a 99% resection. This patient has now a propensity to recur. She's had radiation 5 years ago. Now, do you offer her, the radiation to the residual that you left, or do you kind of just watch and wait, for this thing to kind of, show itself again?
So I think for both of the cases that you presented, they're most likely to be NF2 mutated. So the radiation-induced tumors typically are with marked chromosomal instability. And again, these tend to be as well. I think in terms of for this, I would do a very similar surgery, and I think that's a great aggressive approach and outcome. But the truth is, and I had a patient like this just recently, she's going to recur, and she's going to recur where that little tiny bit of cell was left because of the patency of the sinus. And there's nothing, anyone would do differently about that at the time. And so we've played this game where, then you give radiosurgery, and then you start to see what are the clinical trial options, et cetera. And so what I have found is, and we debate this with our radiation oncologists, whether to just go ahead and do radiosurgery up front or to wait until that tumor starts to progress, but it's going to progress. And based on what we found with the NF2 mutated tumors, they don't recur as quickly as some of the others, but it's probably just a matter of time.
So you'd watch this until it recurs and then give radiation at that time?
You know, I kind of go back and forth because I feel that you're gonna end up having to give radiation, and it's gonna grow after the radiation, and then they're gonna come back to you asking for you to do additional surgery. And then my favorite is when you do the additional surgery and you take this high risk surgery, then the radiation guys say it's, you know, too risky to do radiation after this big surgery that you do. So it goes around and around and around. So, so I don't know, you know, I could really see it either way. And a lot of times I think, you know, the other key thing that we've touched upon is really it's conversations with the patients, you know, and it's patient's preference, and they just need to understand the situation, and they need to understand. And that's why I never say this is a benign tumor, because this is clearly not a benign tumor. I mean, this one's atypical, but I think just them understanding it's radiation now or later, but they're going to get radiated.
And one thing I didn't mention is, you know, we've kind of having this kind of like small little trial of patients who have been treated with like laser, like for these patients who have been, you know, quadruple re-op, you know, radiated patients, and, you know, using lit for these meningiomas, which we haven't had too much success, but we've had a few successful patients. So it's kind of a mixed bag, but.
Yeah, for aggressive meningiomas, we really haven't had much success with lit at all with meningiomas. Yeah. So.
And that's
One comment about the sinus, did not necessarily relate to this case. It is, you know, I do think comfort with the sinus is just a hallmark of when you're doing a lot of meningioma surgery. We like to either see that it's open or closed, and if we see that it's narrowed, you know, that's sort of this grayer area. In certain cases, you know, you can, once you open the side of the sinus, you know, there is an endothelial layer that is defined. And in certain, I don't think in the post-radiated recurrent cases, it's possible to develop that layer, but you can develop that layer, and you've got this, you've opened the wall of the sinus, that dural reflection, and you have tumor you're delivering, and then there's an endothelial layer. So I think there's something to do, even if it's not occluded.
When you take that out down to that endothelial layer, if you can, and you've got kind of this weaker area, do you buttress that or anything at the end of the case to try to support? I mean, it's like
just with like a sized piece of gel foam.
Gel foam, yeah.
I think the other important thing too is to remove the falx, right? You know, because that's always where the tumor comes back to. So I always make it a point to take out the falx as much as I can.
Yeah, I agree. And in that case, that's exactly what we did. Jennifer, was below and interior as far as we could go. We basically just removed all the falx that we could go, and posteriorly, we were limited by those veins that were going in there. And so, yeah, the question is with a large field, radiation field like that, I think, you know, in our approach in this case was just to wait and to watch, because radiating the entire field would create, you know, a lot of difficulty. Whereas if it comes back in one spot, that might be a more localized field. Back soon.
It's a good approach. You're gonna be deploying that weapon at some point,
Right.
And as Jennifer said, it's very high risk to radiate. So
Right. Always high risk, but the surgery not so much.
yeah, exactly.
Well, thank you all so much. This was really a phenomenal session. Definitely one of my favorites, and so I really thank all of you for taking the time out of your Wednesday night to be with us. And I hope you guys all stay safe for the holidays, and take care.
Great to see you.
Everybody.
Thanks for having us.
Thanks. Nice to see everybody.
Thank you.